Because undoubtedly, you'll be sitting there with a patient whose SAT's like 82 and everyone's like getting really anxious. And then you'll just see someone like walk over to the ventilator and start playing with the vent and going up on the FiO2.
Yeah.
Like, stop!
And then you're going to ruin the
Rest
yeah.
the lungs!
Yeah.
Tolerate the SAT!
Toxygen.
We're doing fine! Yeah, toxygen. Oh, I like that. I'm going to use that.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
So Alice, what are we talking about today?
Today, we're putting out part 2 of our ECMO overview series that we recorded with the Cribsiders. In this part, we do a deep dive into caring for the patient on ECMO. This includes managing gas exchange through the flow and the sweep of your circuit and the specialized monitoring that these patients require. This episode is really the majority of what we discuss every day on rounds in the PICU.
And to do that, we're delighted to speak with Dr. Karen Fauman. Dr. Fauman is an Associate Professor of Pediatrics at the University of Chicago. She's a dual-boarded pediatric intensivist and palliative care physician. And also there, she is the Director of the Fellowship Program and the ECMO Medical Director. She is very experienced and extremely knowledgeable and a great guest for today's episode.
Yes, let's get right to the interview. Well, bringing it back to the lung rest of our patient. So we've got this 4-year-old just cannulated onto VV ECMO due to refractory hypoxemic respiratory failure. We're using the right IJ and the right femoral vein. What parameters are we setting on the ECMO pump, and what are our general goals for blood flow, gas exchange, the numbers we're trying to hit?
Yeah. So generally, when you set your parameters, so for a patient who's on VV, like this patient, you are going to initially start going up on your RPMs until you stop getting like a lot of good flow increases. Mm-hmm. So like you start getting diminishing returns as you keep going up on your rate of spinning that disc, right? Because you're just you're not getting enough preload to the circuit to be able to eject. So you push your RPMs up a bit until you start getting diminishing returns, and then you see where your SATs are at. And before you decide how much flow you're going to need over the long haul, you're probably going to want to decrease your ventilator settings to where we put them at rest settings. Mm. But we'll titrate up our flow until we get kind of where we're able to sit. And then we see where your SATs are. If your SAT is 100 with that, and especially if you start having trouble maintaining that flow, back off. You don't need a SAT of 100. Right? One of Dr. Durgam's other great phrases that he used to always say is oxygen is overrated. I say, but oxygenation is not. So we want to oxygenate the patient's tissues, but you don't need your SAT to be 100%. Lots of patients live without a SAT of 100. So the goal SATs in VV ECMO are going to be usually in the 80s because you're not going to be getting your entire cardiac output into the circuit. And this is actually where that extra PO2 times 0.003 starts to be important because your ECMO membrane is going to insert a lot more oxygen into the bloodstream than your lungs do unless you're sitting on 100% oxygen. So the ECMO circuit can increase the PO2 in the blood outside that comes out of the membrane to 300 to 500 or more. And so when you have that much PO2, now when you multiply it by 0.003, it actually has like some oomph, right? It like actually carries some potatoes. And so those potatoes that are swimming around free and not bound to any hemoglobin can go find hemoglobin to bind to in the circulation that's not getting oxygenated by the lungs. So in a VV patient where you might only be able to get your SAT to 75 without that extra PO2, you can get your SAT in the 80s, even if you're not getting the whole cardiac output in there. So that can be really helpful in those patients. So you're going to increase your flow to that. And then your sweep, generally what people will do is they'll pick a sweep that is usually as many liters as your liter flow is. And that's a made up number that we just picked out of the air. And then you get a blood gas and you see what your CO2 is. And if your CO2 is too high, then you go up on your sweep. And if your CO2 is too low, you go down on your sweep. You just try to keep normal blood gases. Yeah.
And talking about the normal blood gas, because I think this makes a lot of sense. You go up on oxygen if you need oxygenation. You go up on sweep if you need to come down on the CO2. Let's say that I am starting my PICU residency rotation. It's Tuesday. I'm the first day. I just took over a patient. I have an ECMO patient. I'm on rounds. They look at me and they say, "Justin, take it away." What are the things that I'm reporting? What are the settings? Someone brings me 3 different blood gases. What am I looking at? How do I interpret them? How am I doing the real goal of medicine, which is not looking silly on rounds.
Yeah. I mean, that is the main goal of medicine, not looking silly in general. Right?
Obviously, right.
Unless it's intentional. It depends on who you're rounding with, right? Because some people feel very strongly about certain things.
Fair enough.
As does anything. Depend on that, right? But I think the main things that you're going to be reporting are initially going to be your flow, your sweep, your RPMs in a centrifugal pump. And then you're going to start talking about your blood gases, like you just mentioned. So the blood gas that you'll probably report out first with that is basically what you're achieving, right? And what you're achieving is what you're getting from the patient. And so you want to report the patient's blood gas. So the patient has an arterial line, ideally in a VA ECMO patient specifically, you want it in the right radial artery, but you're going to report out that gas. And if you are achieving a blood gas of 7.4, 40, 90, good job. You win for the day and you get to not get yelled at on rounds, right?
Normal arterial blood gas, that's the goal.
Normal arterial blood gas. Yeah, usually. I mean, you might want to adjust the CO2 or the PO2 depending on the indication. Maybe there's concern for brain injury. You don't want the PO2 to be too high. Maybe there's concern for pulmonary vascular resistance. You don't want you want to play around with some of the gases in there. But for the most part, you want to look for a relatively normal gas.
The fellow can take care of that.
Do PICU stuff, right? Just do PICU stuff.
Yeah, it's PICU stuff. Yeah. And then there's two other gases that you're going to be measuring pretty frequently. So there's the pre-membrane gas, or the venous gas, and there's the post-membrane gas. And they're for two different purposes. So the pre-membrane gas gives you my most favorite number, which we've talked about, which is the SVO2. Good job. See, you're going to know this stuff by the end. You're going to walk in tomorrow and be like, I will take ECMO patients in clinic.
Piece of cake. Piece of cassava fruit.
Yes, exactly. Avoid the cassava fruit. So French fries. So the pre-membrane gas or the venous gas is to evaluate the adequacy of oxygen delivery and extraction. You may be looking to achieve a certain SVO2, especially in a patient on VA ECMO, because again, the SVO2 is really the thing that we're watching in a patient that has poor cardiac output, and the lactate, obviously. The SVO2 goal in an ECMO patient is going to be at least above 60% because we like a little cushion before we get to that 50% number that makes us super nervous, where you have to start eating cassava root. So you're gonna be looking at that SVO2, and you're gonna then put that into your monitor, which is continuously monitoring your SVO2 with a little sensor on the tubing, so that you can calibrate and make sure that your gases are correlating. So that number you're going to report out and say we're achieving SVO2s of. And then the post-membrane gas, which you're usually just getting about 2 times a day, is really measuring the efficacy and the sort of the condition of your membrane lung. So as your membrane lung ages, it gets clot in all of the little corners and sometimes in other spots, depending on how good a job you're doing anticoagulating. And so you want to see that the membrane lung is still getting that PO2 to the 300 to 500 range. So you really want it to be very effective and efficient. It may start to fall a bit. You'll want to check a couple of gases, but if it suddenly gets very low, then you may have to think about changing out the membrane. And they have like a little pit crew and the specialists, and everyone stands at the bedside and we time them with a timer, and it's really dramatic. And they cut out the pieces and they attach new ones, and they're back on pump in like 30 to 60 seconds, assuming that the pit crew is really fast. But if you start to see that membrane aging, you'll start to see that post-membrane PO2 drop. So that's the number you're looking for in that post-membrane gas. You don't care about the other numbers in that gas. The venous gas, you're really looking at the SVO2 and maybe the lactate. You don't care about other numbers in that gas. The patient gas, you care about the same numbers you would normally in a patient gas.
Beautiful. And just to clarify, when we're talking about the settings, like the oxygen flow, the sweep, and the RPM, 2 quick follow-up questions. Can you go over what some of those typical numbers are? Is flow based on a percentage like it would be? What's a sweep number? Is it like 4? Is it 7,000? And is the RPM for both VV and VA, or is that more for the cardiac pressure that you're supporting?
Yeah, so the sweep is going to be in liters per minute. It's literally an oxygen tube coming from the wall. So it's like 2 liters is 2 liters of sweep. And if you were to take it off, it would literally be 2 liters of oxygen coming out of that tube. And it's just attached to the membrane lung. So that's in liters. The flow is also in liters. Usually if you're on a VA ECMO in a real little infant, that's going to be 100 to 150 milliliters per kilo per minute, or, somewhere in the range of 500 to 700 mLs, 0.5 to 0.7 liters. In a bigger patient, you can go lower on that because they're not going to need as much flow because bigger patients don't have as much needs as an infant. So it'll be like 80 milliliters per kilo, and that might be 3, 4, or 5 liters depending on the size of the patient. In a VV patient, you're also going to have liters of flow, and I titrate those liters of flow to sats down to the amount that we need to sort of maintain the integrity of the circuit. You don't want to keep it going too slow because then you're increasing your risk of clot. So, even if your patient's getting better, you don't drop your flow to like half a liter if you don't have to. You just adjust the sweep and the oxygen, the FDO2, or the fractional oxygen delivered to the membrane in that case.
We talked a lot about how the venous oxygen saturation can give you an idea how well and adequately you're delivering oxygen. We also have NIRS on these patients, and maybe a full discussion of NIRS is maybe a bit beyond what we're doing today, but what is that essentially and how do you use it?
Yeah, so I'm not going to do it justice, but I'll try. So NIRS is like what I refer to as a poor man's SVO2, but only because I'm biased and I didn't have them growing up. Most would say it's actually probably a rich man's SVO2 because it's really, it's an expensive piece of machinery. It's a proxy for microcirculatory oxygen saturation. So it's really like you put a NIRS on the forehead, you put a NIRS on the flank, and you want to see, essentially, it's measuring like a venous saturation. So those numbers should sort of be reflective of what you'd see in an SVO2. The other nice purpose for them in ECMO is actually that when you have a patient who's cannulated through an artery that is perhaps important for blood flow to a limb, let's say femoral artery or axillary artery, you can actually put a NIRS on that limb and make sure that they maintain adequate oxygen saturations in the adequate NIRS readings on that limb to make sure they're not getting ischemic. The other thing you could do is just put a reverse, like a little cannula in there to return some blood flow distal to the cannula, but both would also be ideal. So we do use the NIRS in those patients. And the other situation where that might be helpful too is on VV ECMO. There's this special situation that you can run into where that SVO2 number might not actually be reliable. And that is a situation where you have recirculation. And recirculation is when the blood coming out of the circuit to the patient gets sucked back up into the drainage cannula or drainage lumen. And you get overly oxygenated blood to the circuit and decreased oxygenation to the patient. And so what you start to see is a reversal of your venous saturation and your arterial saturation. So now your SVO2 was 65, but now it's 82, and your arterial saturation is 74. That's not ideal, right? Because you're not trying to oxygenate the circuit, you're trying to oxygenate your patient. So in that situation, in a patient on VV ECMO, you don't actually have totally accurate, like you can't really use the SVO2 as a full proxy. So in a patient who's on VV, whose SAT is like hanging right at 80%, like right as marginal hibernation as you can get, and their SVO2 is not reliable, you're really going to have to depend on your lactate to tell you whether you're adequately oxygen delivering. That's one time the SVO2 doesn't do it, but the NIRS might. So I have to give it up to the NIRS for that.
Yes, a reluctant acknowledgement. And that is really, it does seem like so much of the game is, can you get the flows? Can you safely get enough blood oxygenated to oxygenate your VV ECMO patients? And can you safely get enough blood moving for your VA ECMO patients, right?
Correct. Yeah. And sometimes you're tolerating stuff you don't want to tolerate. And you sometimes have to like cover the saturation on the monitor so no one looks at it. Because undoubtedly, you'll be sitting there with a patient whose SAT's like 82 and everyone's like getting really anxious. And then you'll just see someone like walk over to the ventilator and start playing with the vent and going up on the FiO2.
Yeah.
Like, stop!
And then you're going to ruin the lungs.
The lungs! Yeah. Tolerate the SAT.
Toxygen.
We're doing fine. Yeah, toxygen. Oh, I like that. I'm going to use that.
Now, the other thing that we need to be looking at on the circuit is the pressure monitors. What should we be worried about when we start to see those change?
Yeah, so, it's funny, they don't actually use pressure monitors so much in the adult ECMO circuits. So this is kind of a little bit specific to pediatrics in some places. It depends. But you're going to monitor it in 4 different places. So you're going to monitor the inflow, which is that when you're talking about inflow and outflow, you're talking about the ECMO circuit because we're not talking about the patient in this situation. ECMologists and ECMO specialists in particular really are like circuit centric. Mm-hmm. So the inflow to the pump and the outflow to the patient pressures. So let's say the inflow pressures are the pressures to the pump. And those are really telling you about your preload. So they're telling you if the circuit has enough volume in it to maintain what it's doing. If that number gets too negative, that means that the circuit is sucking blood away from the patient. And if that number gets really positive, that means that you're filled up enough. The danger zone comes in that situation when you get to, most would say, less than negative 100, because that negative 100 is where you might see cavitation. And cavitation is when bubbles or air is pulled out of solution. And you then get air in your pump head, and that is another no-go, no bueno for the circuit. So you try not to entrain air, obviously, into the pump. So that's your inlet pressure or your inflow pressure. Then there's the outflow pressure, which is basically a measure of the afterload to the pump. So that's your patient's SVR, if there's a clot in the arterial cannula or the venous return cannula. When that number gets very positive, it means that that's very resistant to flow. The other situation where that can happen is if your cannula that was placed is too small and it's just not adequate to deliver the flow that you want it to deliver. And so if that number gets very, very high, you might need to either think about your cannula, think about a clot, or think about dropping your patient's SVR with a vasodilator. So nicardipine, nitroprusside, something to decrease resistance to flow. And then the other pressure, and actually your inflow pressure can also be affected by the size of the cannula, to be fair. And then the other pressures you're going to measure are the inlet and outlet pressure of the membrane. And this is really just measuring what we call the delta or the pressure drop. Mm-hmm. The pressure drop is what change in pressure there is across the membrane. And that number increases as you get more clot in it. So that delta will go towards 100. When it gets about 100, that's about time to think about changing out your membrane. Overall, the measurements, just like any other thing, just like CVP and NIRS, are really trends. So the absolute number is not so important for the most part, except for that inlet inflow pressure. You don't want that to get below negative 100. Some will tolerate it to negative 150, but you're playing with fire a little bit at some point.
So this is great. I mean, it sounds like these are a lot of those other things that we're monitoring for our rounds presentation. And it's cool to hear that it sounds like there's almost two patients. One is the patient and one is the membrane.
That's right.
Of making sure that these clots and things aren't breaking I don't know where ECMO is in the train station, but that's okay. But one of my question I've been looking forward to ask, let's say I'm on rounds. I did a great job. I presented the gases like I knew what I was talking about. The sweep and the flow are doing well. The delta pressures demonstrate that the membrane is healthy and going strong. And then the nurse pulls me aside later and says that there's some chatter. What is chatter? What I do? What I mess up?
Yeah, you didn't mess up anything. So that's chatter is one word. People also use the word chugging sometimes. Some people will differentiate. So chatter might mean the visual evidence on the monitor of changes in flow, kind of going up and down with the digital readout. But more what the nurses are usually talking about is the visual evidence of turbulent flow in the tubing. And you'll actually see that tubing like moving up and down or swinging back and forth. And that's usually, I say, it's one of two things. It's either inadequate volume to the circuit, inadequate preload, in which case you might be seeing those inflow pressures be too negative, right? So you need to give volume to the circuit in order to flow it more. Or more often, I find, it is the overly exuberant expectations of the care team, right? So we're asking for too much. We need to calm down a little bit. If this patient's SAT is 90% and they're on VV ECMO, back it off a little bit.
We're okay with little chatter.
Yeah, because you don't want to have to do so much lung dialysis, right?
Right.
You want to have to dialyze that fluid off.
It's not entirely,
You want to get the fluid. You don't want to give more fluid or blood than you have to. So ideally, if you get chatter and you have room to back off a little bit, you might back off.
Mm-hmm. So overworking the circuit and not so much just a clear measure of the patient's volume status.
Right. It's kind of both. It's the circuit trying to get more flow, but not being able to achieve it. So either you're asking for too much flow or the cannula is too small, which is not usually the case because we are pretty good about getting the right cannula in, or there's not enough volume, or you need to back off and stop asking for so much.
So when I'm in the PICU taking care of these kids really, really sick and we're worried about them going on to ECMO, it's almost like when they actually get on ECMO, I just take a sigh of relief because a lot of things change. Do you mind just telling our listeners outside of the ECMO circuit, how do you change your management, really in broad strokes here? No reason to get into very much detail because just thinking about our learners coming in, what are the big changes that you'll do for a patient's physiology differently when they're on ECMO?
Spoken like a true ECMO PICU fellow, right? You're like, thank God they're on ECMO. Everything's going to get so much less scary now.
Ooh. I never said that in residence.
That is the exact words that say, like, oh, thank God my night's going to be so much better because they're on ECMO now. There's a few things that are going to change pretty significantly. One of them is going to be that in general, because these patients need to be anticoagulated, especially little patients, the smaller they are, the more important that's going to probably be, is that you need to be really careful about things that we're doing that we would normally not think about. Placing a peripheral IV or an NG tube can be lethal, right? Because they can bleed out. Now, I always say on an ECMO patient, it's better for them to bleed in a place where they can actually let the blood out than it is to bleed into an enclosed space. So at least if you place an IV, you can like wrap it and pack it and all sorts of other stuff, or hold your anticoagulation for a minute. So bleeding is kind of one of the primary things you worry about. For a patient who is newly on ECMO, you are going to initially have them relatively sedated until you get them stabilized enough. And then depending on your program and the comfort level of the people at the bedside, your goal is going to be to let them be as awake as they'll tolerate and as awake as you can support them so that you can allow them to rehab. There are patients that walk around, that sit up and eat, that do bicycles. I think I saw Meg Scheffler was on one of your episodes, and she is a friend of mine. And I don't know if she remembers me, maybe we were certainly friends. She told me about a patient that they had at Hasbro where they had a little tricycle that the kid was riding around the ICU on ECMO. So you want to mobilize them as much as you can, but you have to be careful, obviously, because, you've got that big hose draining all their blood all the time and then returning it. And then for a respiratory failure patient, you're going to put them on rest settings on the ventilator. So that's going to look like kind of a PEEP of 10, inspiratory pressure of 10, a rate of 10 or 15, and a long inspiratory time, and as little FiO2 as as the patient can tolerate, 40% or less generally. And you may see no lung volumes. So you might see on your chest x-ray a totally whited out chest x-ray. And I once got a chest x-ray read after we cannulated a patient for ECMO. The radiologist actually called me and said, I just wanted to talk to you because this is the worst ARDS I have ever seen. And I said, yes, thank you. I know that's the diagnosis I would give him too. And he said, and also there's a very large catheter sitting with its tip in the IVC. Is that intentional? I said, yes, you've identified the ECMO cannula and the reason that we can see this patient's lungs despite that. But what you don't see there is any air spaces. And you can expect to not see any air spaces for some period of time. And I usually tell the residents and fellows not to try to be recruiting or aggressive at all with the lungs until they start seeing air bronchograms. And I describe it as, do you guys know the book A Tree Grows in Brooklyn?
Yeah. With the alcohol and yeah.
So there's a little girl who was like raised in the tenements at the turn of the century, and she thrives despite being in a very difficult and very trying environment. I think of the air bronchograms as a tree growing in Brooklyn. The little buds start coming out, you start seeing little branches, and then you see another branch, and then you see another branch, and then you start to see little leaves at the end. Those are your alveolar sacs, and you start to literally see it grow over a few days. And once you start to see those trees growing, that's when you start to know that the patient might be starting to get better, might be recruitable. You might be able to start to work on their lungs a little bit. And then the other thing you might do in that patient is bronch them to see if you can clear out their lungs a little bit.
I really appreciate that and needed to hear it early and now, because in my mind, it's very hard to just sit and wait for the lungs to recover. And so giving a little something to look for every morning at x-ray rounds, like, you see that air bronchogram new from yesterday is I think very positive.
That's positive, right? And as those branches branch other branches, you get excited and you start to say like, well, maybe I'll try a little bagging at a pressure of 30 today and just see what they do. And then you see if they develop tidal volume or get an end tidal waveform. And so you're going to not see any end tidals in these patients who are on VV. In a patient on VA, you are not necessarily going to do rest settings, right? You want to maintain the pulmonary vascular resistance at the prime. You guys did West zones in med school.
Oh, yeah.
Don't make me don't try to, I can't teach that effectively, but you want to maintain the best, lowest PVR that you can in a patient who's got cardiac failure, of course. And so you're going to try and keep those patients appropriately recruited, not over-recruited, not under-recruited. So those patients are not necessarily going to be on rest settings, but your VV patients are going to be on rest settings.
Nice.
And that makes sense because also the tricycle patient is going to clearly be on VA. Is that safe to say, like the VV?
Either one.
You might be extubated doing okay and still be on ECMO.
Sure. Yeah.
All right. Well, let's turn over to Alice's question because I think that might get to it actually.
Yeah. Well, we were going to pivot to really the process of starting to wean your flows, wean your FiO2, and how you know when someone is ready to be liberated from ECMO.
Yeah, so let's separate the two types because I feel like I've been a little bit confusing, not like differentiating each time. But
yeah.
So if you have a patient, I think VV is like way more interesting and way more complex in some ways, but let's start with VA because VA is basically heart-lung bypass, right? And so if you have a patient on VA ECMO, things that you will see that are signs of recovery are going to be increasing pulsatility, which means the arterial waveform on their art line is going to start to be bumpy again, when previously you might have had a blood pressure of 80/72, right? Now, you need to maintain some pulsatility, some bumpiness in order to eject from the left heart while the patient's on VA ECMO. Otherwise, that pressure and that blood that goes through the lungs and gets to the heart builds up and dilates that LV, and then they can get back pressure on their lungs and have a pulmonary hemorrhage. So you need some pulsatility. Ideally, you need a difference of at least like 10 between your systolic and your diastolic blood pressure throughout the ECMO run to maintain adequate ejection. But let's say that you had just 10. Now you're going to start to see that your pulse pressure gets to 20 and 30, and you're not needing any vasoactive agents to maintain that. And you start seeing it actually cardiac squeeze on echo. You start seeing the patient tolerate movement and wakefulness. You start seeing their lactate stay nice and normal and their SVO2 not dip every time they move around. And you start seeing the ability to wean your flows without a significant change in your hemodynamics and your lactate. Now, you don't want to wean your flows all the way off or super low because, again, you don't want to clot your circuit, but you can wean them pretty low, at least for some period of time, to check and see if they can support themselves. And so in VA ECMO, you'll wean them as low as you feel is safe for your circuit for a little while, and then you'll probably go back up to maintain the circuit. And then when you're really ready to trial a patient, you'll do what's called a clamp trial. And this is where you get all of your stuff ready just in case. You get epi spritzers, or some people call them dwindle epi. You get your bicarb, you get your calcium, you get all the things ready, and you put your epinephrine in line, and you slowly wean down the flows until you're off, and you clamp, and you let the patient go, and you see what they do. You usually keep them relatively sedated for this so that they don't have to do extra metabolism from being awake. And you see if they can tolerate it with minimal vasoactive support, minimal epinephrine and such things. And see that their lactate's okay, make sure that their SVO2 is okay. And you can do this for half an hour to an hour. You really don't want to clamp for much longer than that. And then you'll go back on and decide, did they tolerate that trial? Are they ready to come off? And if so, then that's when you come off circuit. For a VV patient, it's actually a little easier to trial them because you don't have to clamp the circuit in VV. If your patient has evidence of tidal volumes, chest rise, is able to get a tidal volume that's, 4 to 6 per kilo on what are either rest settings or lower, I actually like for them to do this on extubatable settings. I definitely get some flack for that because that's like people like to get off as soon as they possibly can. But, I went through the pain and process of getting the patient on ECMO. I don't want to take them off until I know they're better. So you can get them to extubatable settings. You want to see that you have a good tidal volume, that your end tidal CO2 is similar to your PCO2 on a gas, which means that you're exhaling the same amount of CO2 that you are seeing in your blood gas, and that means the circuit's not doing as much. You want to see that your sweep is coming down, that the patient's tolerating being awake with the sweep down. They can tolerate physical therapy if they're old enough to be awake and doing that while on circuit with their sweep down or off. And then you want to see that they're not needing more than, I usually say, 50% FiO2. And then you're going to, instead of necessarily, depending on whether their issue is more oxygenation or ventilation, you're going to either wean your sweep way down or just disconnect it from your circuit, or you're going to wean your FiO2 or FDO2, your delivered oxygen to the circuit, down to closer to room air. And you can hang out with no sweep on for 24 hours if you want to really prove to yourself. Make sure they do I had a COVID patient where I made sure that they could do physical therapy off sweep and tolerate it without having significant downtrends in their respiratory status. And they did. And so they were ready to come off. So that's kind of how you know.
It's a good answer. It's almost impossible to answer that in a succinct way because you have to be at the bedside. You have to look at the patient. You have to know how sick they were when they went on to ECMO and what their trajectory is currently and where they headed moving forward.
Yeah. And if you're not having complications, especially in a patient who's on VV ECMO, where the risk is lower than being on an arterial, having, an arterial blood flow cannula, the better part of Valor is to sit tight for a little while if you're not sure, because it's a good support in the meantime. And so I tend to be a little bit later to come off, especially on a VV patient, because I'd rather really get them better first as much as I can. Now, if they're having complications, if they're bleeding, if there are other issues, or if we realize that they don't have a reversible illness, or they're not a transplant candidate and their illness isn't reversible, that's a different conversation.
So for our learners, they come into the PICU, they see this patient sedated, paralyzed, 2 big cannulas coming out of their neck. It looks really morbid. It looks like this patient might not make it. But what outcomes should our learners expect for patients on ECMO? And maybe is there a certain patient populations that do better, maybe some that do worse?
Yeah.
What are your thoughts?
Yeah, so there's lots of patients that do really well. And I mean that more than the vast majority get off ECMO and do fine. There's a great photo of Dr. Bartlett putting the white coat on a first-year med student at Michigan who he had put on ECMO as a baby.
Whoa.
Yeah, I know. It's a good one. I would say the vast majority of neonates who go on for persistent pulmonary hypertension of the newborn or meconium aspiration syndrome or neonatal sepsis, they almost always do well and come off relatively quickly. Now with the advent of nitric oxide and oscillators, we tend, and better, surfactant and better ventilation methods, a lot of those babies don't have to go on anymore. But the first patient he ever put on was a meconium aspiration with PPHN, who now comes to the ELSO meeting every year and has kids of her own. But those patients do really well. The patients who don't fit the criteria we talked about, though, are the patients who do less well. So, there is a lot of controversy about whether we put on patients that are very high risk. Oncology patients are kind of the hot topic right now. And, when you talk to an oncologist, they're sort of used to dealing in really low numbers, right? They're used to dealing with patients that have a 10% chance of survival. And they don't go well, we're not going to do anything. They still want to move forward with that. So it's hard to tell an oncologist, this patient only has a 30% chance of survival, so we shouldn't go on ECMO, right? That doesn't make a lot of sense in some ways. But even in the oncology population are patients who will do better than other patients. So the patients that do the least well are the ones who have a long time until their immune system is going to become intact, who still have active disease, who are going on for unclear reasons or for a viral infection that they're probably not going to clear. Those patients do less well in terms of if you're looking at the whole population of ECMO patients.
This has been great. I think we've really covered, the indications for ECMO, for VV ECMO with respiratory failure, with VA ECMO for cardiac or other perfusion difficulties. We've talked about how we're monitoring this, how we can look smart on rounds when we're talking about sweep and flow and the gases and monitoring the second patient, which is the big box in the room. We've talked about the outcomes and kind of how we're transferring people off ECMO, and they often do quite well. With all these kind of big topics, do you have specific take-home points, or what do you think the main points should be, whether it's a medical student who's thinking about at-home ECMO, a resident who's doing their first day in the PICU, or a fellow who's teaching this and pursuing this? What are some of your main take-home points for our listeners?
Yeah, I think it feels daunting, but ECMO is really about, like I said earlier, about oxygen delivery. And if you understand the need for oxygen delivery and how it works, then ECMO is actually relatively simple to understand in some ways, but also that ECMO is very resource and personnel intense therapy that you really need to be thoughtful and thorough about deciding when and how to apply it, because it has, not only is it resource and personnel intense, but it also has complications and has lots of things that can go wrong as well as things that can go right. And so as far as therapies we provide go, I really think it's our job to be stewards of this particular therapy and to help families. I sort of make a plug here for my other role, which is palliative care, that while people sometimes think that ECMO and palliative care are weird interests and disparate interests to have, I actually think that they're really on a continuum. And if you're going to put someone on ECMO, you have to be thinking about what happens if this doesn't work or if we have a really big complication. And is it worth the risk of the complications, but also is, what happens next if we can't get better. And so I think keeping that in mind all the time and keeping in mind with the present state of the world, what sort of need there is, I think those are really important points for all of us to be thinking about.
Fantastic. Well, thank you so much for talking with us today. Before you go, is there anything else that you'd like to plug in terms of resources, things listeners should check out?
Vaccines. Get vaccinated against everything. Please, God, get vaccinated.
Flu shot team.
Flu shot, COVID shot, boosters, Pentacell, all the things. Please.
A little general pediatric tidbit into this ECMO episode.
Yeah. For the primary care providers out there, nice. Yeah,
Stay
it's good to throw them a bone in this.
Yeah. Help me not have to help you is what I usually tell people.
Yeah. This is excellent. I think this has been a fantastic episode that's going to benefit a lot of learners. This was a great throwback to my experience in the PICU, which was a bit traumatizing, but I think had I had this episode going in, I would have been ready to just sweep away all the negative. That was forced. That was too much. But we are very great. Small potatoes. That was the better pun. Karen, we appreciate you coming on. We appreciate you sharing your time and your expertise. Thank you so much for coming on this episode with us. We really, really appreciate you. Thank you.
Thank you.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.